This is an interview being conducted with Dr. Charles E. Troland, and it's being done in Richmond, Virginia on May the 6th, 1988. Dr. Troland, tell me where you were born and about your early life. And
I was born in Fredericksburg, Virginia, of Irish ancestry. In fact, my grandfather had to swim for the boat when his people lost in the war over there. He came to Fredericksburg, Virginia. I do not know how I happened to I went to the schools in Fredericksburg, the public schools, and graduated there. I don't know how I happened to go to Hampton-Sydney, but it was an extremely good choice. Hampton-Sydney is a small school. At the time that I was there were just a few over 200 students, about 25 of whom flunked out at the end of the first year. It's grown more since then, but it had an excellent faculty to student ratio, so that the professors all knew each other, and they knew all the students and knew them well. I think one example of that, which would be of interest, is that Professor Overcash, who taught biology, met me on the campus when I was about to graduate and asked me what I planned to do. And I said, my mother said I always talked a lot. And I was on the debating team, and she thought it would be a good idea to be a lawyer. So I planned to be a lawyer. And I told that to Dr. Overcash, and he said, no, you don't want to be a lawyer. I said, why don't you go into one of the humanitarian professions, like being a doctor? And I thought about it and decided I wanted to be a doctor. So I called my mother, who was always my closest confidant, and I told her, and she said, that's all right, where do you want to go? And I said, well, I've heard that Johns Hopkins was a good school. And she said, well, you can't get in there, it's too late, but go ahead and try. And so I did get in. And it was a extremely good 4 years that I spent there.
what year, Dr. Troland, did you enter Hopkins? Do you recall?
I graduated in 36, so I went in 32.
You received your MD degree from Hopkins
From
in 1936. What did you, at that point?
At that point, as each passing year went by, I knew more and more I wanted to be a surgeon rather than a medical man. I didn't have any particular interest, but was thinking somewhat about the nervous system. And Dr. Clinton Woolsey, who was a neurophysiologist, was working in the Department of Neurophysiology under Dr. Philip Bard. And he suggested that I work with Dr. Bard. And I went over, and Dr. Bard allowed me to work with him for the last 2 years in all of my extra time that I had from my usual classes. He also, at the end of my third year, suggested that I go to Montreal, and I went there during the summer of my junior year, after my junior year. I didn't see a great deal of Dr. Penfield, but worked very closely with Dr. Coleman, mostly on slides. And then I was trying to decided that I wanted to get a surgical internship, so I applied at Hopkins. I didn't have anyone to push me for the job, so I would go down and every Friday at Dr. Dean Lewis's, the professor of surgery's clinic, and sit at his right elbow so that if someone missed a question, he could turn to me. And so he remembered me from that and gave me a job, which was as intern in surgery. It was an extremely interesting year. My first experience in the operating room, I was first put on surgery, on neurosurgery, and my first experience was with Dr. Dandy. And during that first 6 weeks in the service there, an intern would spend 6 weeks on neurosurgery. And he fired the resident and the assistant resident, but I escaped. I went back later in the year and traded with someone else so that I could have another 6 weeks on neurosurgery. which I was delighted to have. I was then, the question was, I wanted to get in line for the surgery and surgery, which was quite long at Hopkins, amounted to 10 years, 2 of which years were put in neurosurgery. And so I went to Dr. Lewis and applied. I didn't see him, but sometime later, nothing had been heard. And so I met him on the elevator one day, and Dr. Lewis was very close-mouthed. He was a very good friend of Dr. Dandy's. And he said, come to my office on Monday. So when I went there thinking delightfully that I had a job, I found all 8 interns were there. And his secretary sent us away and told us to come back in another week. So we went back the following week, and on the 3rd time over, with all 8 of us there, disrupting the entire surgical operating room, he went down the line. I was standing on one end, and he went down the line, and he told each person where he was sending them, to Michael Reese, or to Cornell, or to the Mayo Clinic. And when he got to me, he only said, and as for you, Troland, you're only dogging my footsteps. So I went away, and after 2 weeks, I still didn't know anything. And thinking that Dr. Dandy might remember him, I asked him what he could do, and he just smiled and said, Dean is just pulling one of his funny tricks. And the next, about 2 days later, Dr. Lewis met me in the hall and told me to come to his office and said, you have the job, of course. So I went from there to the Hunterian Laboratory under Ferdinand Lee and published several papers on thrombocytopenic purpura. And we taught dog surgery over there then. And before anyone could get married, they had to get acceptance from Dr. Lewis. You had to ask him before you could ask your proposed bride. Well, I came after the Hunterian Laboratory. I went over to the pathology lab as William Stewart Halstead Fellow in surgery. And there I came to know Dr. Dandy much better, as he came over 2 or 3 times a week. And we worked in neuropathology and general pathology during that time.
What was the status of neurosurgery in Dr. Dandy at that time? Was this in the zenith of Dr. Dandy's career at Hopkins, or was it just...
Yes, Dr. Dandy was never a member of the paid staff at the hospital. He was always in private practice. Neurosurgery was not a separate division. Neurosurgery was where you spent 2 years on the general surgical setup. For instance, you spent the first year as an intern in surgery, which included neurosurgery, then a year as the Hunterian Fellow, then a year as a William Stewart Halstead Fellow, and then came right back to work in the emergency room, and then worked for another 5 years up, so that the 10th year you were resident in surgery, but you had by then had 2 years in neurosurgery.
I see. Was it a sought-after position to work with Dr. Dandy at that time?
Well, it wasn't for Dr. Dandy. A large number of people would come in to watch him work, but the service was not really an individual service. You did not work for Dr. Dandy. You were working for Dr. Lewis, but it was an autonomous service. It was kept off so that you just worked through it, but there was no strict control by surgery over neurosurgery.
By this time, then, Dandy was a well-recognized figure in neurosurgery circles. And
extremely well recognized.
so then, through this work in the lab, and you were publishing papers and beginning to work with Dandy, then, as he came over to the laboratory, you got to know him well?
I got to know him very well. The laboratory assistant was a good friend of his, and he used to like to come over when he finished rounds just to spend a half an hour. At the end of that time, I was supposed to go back to working in the emergency room in surgery, but Dr. Dandy took an instinctive dislike to the man who was ahead of me, and so I missed that year, which was the easiest year up to the residency, and went directly into neurosurgery as an assistant resident. Dr. Dandy did not have very much to do with the assistant resident. The most important person in the operating room was the resident, and then the scrub nurse took second place, and perhaps third place was the assistant resident.
Were these the days of the so-called brain team, and had it evolved into a real formal program then?
Yes, everybody went through it, but you were considered sort of off by yourself. You were the resident, and you were a very important person in the hospital because Dr. Dandy got everything he wanted. He used to feud with the operating supervisor entirely because she wouldn't buy him a catheter on one occasion to put in one of the patient's ventricles. And he didn't forget easily. He kept that feud up. I went back in as an assistant resident. You just worked very hard for Dr. Dandy. You made rounds at night at about 2 o'clock, because when he called you, he would want the 12 o'clock or 2 o'clock temperature and not an earlier one. It was a very fortunate time at Hopkins then, because there were some very great men there. When you were on Dr. Dandy's team, you had ready access to Dr. Frank Ford in neurology, Dr. Walsh in neuro-ophthalmology, and Samuel Crowe in otolaryngology. And they were all excellent, and they would all come in and love to go over the patients. When Dr. Dandy went away on a trip, they all came over and went over all the patients. It was a pleasure to work with him.
And as you advanced through your training, did he let you do more and more of these operations with him, or did you work closely in the operating room with Dr. Dandy?
All the time. Dr. Dandy said very few things in the operating room. The instruments were laid out on a table, and everyone knew what to hand him. And it was really a pleasure to see him work. He was a master.
What was his outstanding characteristics that attracted you to him, and that may have rubbed off on you over the years? What did you really learn from Dandy?
Operating technique more than anything else. Dr. Dandy himself always said that he got many accolades from his research work, but he was primarily an operator, and that's what I learned from him more than anything else. He did not go to the laboratory very much when we were there, but you were supposed to spend 2 years with him and then go back into general surgery. And during the time that I was an intern at the hospital, one of his former students was a resident in surgery, having been through neurosurgery, was Barnes Woodall, who took over the service at Duke.
Now, there were other neurosurgeons on the staff at Hopkins that you became very friendly with over the years. Is that not
Yes,
correct?
but there were ones that came along later.
Later.
At the time that I was there, Dr. Dandy was the only neurosurgeon at Hopkins.
Now, as you were going through your training, I understand your residency, as it were, was interrupted by military experience.
Yes. Well, before that, when neurosurgery was a part of general surgery, Dr. Dean Lewis, the professor of surgery, died, and Dr. Alfred Blaylock came up from Vanderbilt and took over his job as professor of surgery. And he decided on that occasion to split off neurosurgery from the general surgical lineup, which was the logical thing to do. And so it was decided, I at that time was a resident in neurosurgery, and it was decided at that time that I would stay on for another year in neurosurgery. The only thing was that on December 7th of that year, the Japs attacked Pearl Harbor. And I went overseas with the 18th General Hospital, which was the Hopkins unit. We went first to Auckland, New Zealand, and then we were permanently stationed at Fiji. I left the hospital on several occasions on detached service, went in on the invasion of Bougainville. And then when I came back to Fiji, we eventually went, when everyone thought we were coming home, we were sent to India, where we were stationed at Margarita, which was at the head of the Ledo Road. And we were, eventually, they had determined that we would go down to Myitkyina in Burma, but instead of that, we were sent home.
What was the military experience like for you? Did you do neurosurgery or general surgery or everything?
Well, we did everything except I did all the neurosurgery. I was chief of neurosurgery, But there wasn't enough neurosurgery on many occasions, so she just joined in the line of doing the appendices. For a large part of the time, we were really just the staff physicians for the 37th Division. There weren't many casualties coming in until we finally got those from Guadalcanal, and my most enlightening experience was going up forward on detached service.
Did you have antibiotics available for your cranial wounds and things at that time?
No,
No antibiotics?
no.
So when you came home then, you returned to Hopkins and completed your training? And
No, I didn't go back into Hopkins at all. Dr. Blaylock said that he would take me back in there, but that he felt I'd had enough neurosurgery. And the plan had originally been, when I stayed for an extra year in neurosurgery, for me to stay there at Hopkins. But the war broke that up. And when I came back, Hopkins was in a dilemma. They were changing over to a full-time system. Dr. Dandy, as I said, has always been on private practice, and that was it. The hospital never paid him a thing. And he decided then that one of his good friends, Dr. Coleman in Richmond, needed someone. And he said my future would be better with Dr. Coleman than with him.
tell me about this incident we always hear about, and that's the relationship between Dandy and Cushing. Would you like to shed any light on that? You were there during much of the
Well,
time that Dr.
was
Dandy
there.
and Dr. Cushing were very active in neurosurgery.
Dr. Dandy had a deep and abiding hatred for Dr. Cushing, and I think Dr. Cushing had the same thing for him. That was never smoothed over. It dated back to the time when Cushing left Hopkins to go to Harvard. And he told Dandy originally he was going to take him, and then at the last moment didn't take him. And was going to take Dr. Samuel Crowe instead, but Halstead talked Crowe into staying at Hopkins. And mainly that trouble came out of technical grounds on pontine-angle tumors. When Cushing really accused Dandy of lying and of not doing right in publishing, but Dandy said it was only a preliminary report. But there was an abiding hatred. When Cushing died, Dandy only said Cushing died. And that was where the entire matter ended.
Did you ever meet Dr. Cushing
No,
during your career? Did he ever appear at Johns Hopkins while you were there?
no.
Never.
But Dr. Dandy's best friend, it was interesting that two people whom he hated, and they hated him, were in the neurosurgeon in Philadelphia. But his underling was one of Dr. Dandy's best friends, Chubby Grant. And one of Dr. Dandy's very best friends was Dr. Gilbert Horax, who came down on frequent occasions and was one of Dr. Dandy's biggest boosters. When a large number of people made remarks about him, he told Temple Face that the only reason that you say anything about him is he's 20 years ahead of us. And Gil Horrocks was a perfect gentleman.
So about what year then did you come to Richmond?
1945,
After the war.
yes.
And Dr. Coleman was well established in Richmond at that time.
Yes.
He was an important figure in neurosurgery.
Well, he was the only figure in Virginia. Dr. Coleman started neurosurgery in Virginia. He was a general surgeon, and he picked up more and more neurosurgery until he became professor at the Medical College of Virginia. He also became professor at the University of Virginia and used to go between the two of them. But eventually they decided to get someone entirely to be at the university, and so they took one of his men, Dr. Gail Crutchfield, who was practicing with him in Richmond at the time. And Dr. Meredith, who was at the University of Virginia, came down here to be with Dr. Coleman.
Did Dr. Coleman have any formal neurosurgical training?
He went to a lot of small teaching sessions that Cushing had. And that's where he met some of the people in Philadelphia. But I don't think he ever had any, he certainly had no residency or anything of that sort, but there weren't many residences in those days.
So you started in Fredericksburg, went to Baltimore, and then came to Richmond and joined Dr. Coleman here
Dr.
on
Coleman.
the staff. Would you tell us a little bit about your experiences with Dr. Coleman and your early practice here at the
Well,
university?
unfortunately, I can't say very much about Dr. Coleman because he was in very much his declining years when I arrived here. And he only operated on 2 occasions, and he had to have oxygen while he was in the operating room. So I didn't see him, but I saw what he had built up. And he used to go all over North Carolina, and because there was no neurosurgeon there at that time. There was no neurosurgeon south of Richmond. And think of what a plethora there is now.
Yes, and he had you as his associate and Dr. Meredith.
Dr.
There were
Meredith.
3 of you here
Yes.
at the Medical College of Virginia in the late 40s and
Yes.
early 50s.
And Crutchfield was at the university, and that was all. And then Dr. Thompson, after the war, went to Norfolk.
What was the practice of neurosurgery like? Tumors and spine
Tumors
cases?
more than anything else because there were so few neurosurgeons all throughout the South and all from here down that your service was pretty well full of tumors.
And mainly that was a big part of your practice. Is
That
correct?
and trigeminal neuralgia.
Trigeminal neuralgia.
We saw an awful lot of those. Dr. Coleman used to say that they came out of the mountains in the spring and went back in the fall, so you had to get your cases in between because they couldn't get out the other time.
How did you treat trigeminal neuralgia in the late 40s? What did you do, Dr. Troland, for a patient with tic-douloureux?
I've always been strongly in favor of the posterior approach to tic-douloureux. It's been popularized a great deal by Janetta and I in taking the vessels off the nerve, but we didn't take the vessels off the nerve, although Dr. Dandy realized that might be, in many cases, one of the agents that was producing trigeminal neuralgia. But I did the tics, I did some of them by the posterior approach, but at the time I arrived here, Dr. Coleman had already done 2,000 by the temporal approach with no discs. And none of them had any real bad morbidity. And so I could see on that occasion myself as a young man comes to town and loses a tic. So I did a large number of them by the temporal approach then, but I always believed in the posterior approach.
Did you do any pericutaneous blocks, say, to the Caesarean ganglion or anything? Or was
Dr.
that not
Coleman and
pop-
Dr. Meredith would do those.
would do those?
I was never very much with the needle.
What about the evolution of spine surgery and disc surgery during this time? Was that coming of age? And
Well, it was, I started out with the first operations that were done for disc at Johns Hopkins Hospital when I was a resident were done by a completely open approach as over a spinal cord tumor in which a laminectomy was performed. And then we gradually got down to the so-called modern method of just going in on one side and taking out the offending cartilage, which I still believe is the best method for the treatment of lumbar disc.
I've had the privilege, Dr. Tolan, over the years of meeting a fair number of patients and people in Richmond that you treated for hypertension by a sympathectomy. Would you tell us a little bit about your approach to that problem?
Dr. White in New York was using that. Many people were very much in favor of it. There were several doctors here, surgeons in the hospital, who had hypertension and had been operated on in Boston and other places and had gotten good results. We did it for a long time. It's a big operation, a large thing on both sides. We never did the small operation that was used by Max Pete of going in just into the thorax, but we did a thoracolumbar sympathectomy on each side. And actually we got some very good results, we got some bad results, but on many occasions the bad results were those that should have been operated on very much earlier. But we really did get some good results with the sympathectomy and stopped doing it mainly because of the other drugs had come in and could do essentially what the sympathectomy would do. But we had good experiences with them.
Would you reminisce a little bit about your practice in Richmond over the years and maybe some of the high points and low points, the things that you liked to do and felt comfortable with?
Well,
Things that were unique maybe that you did.
For a great deal of any neurosurgeon's practice for lumbar disc surgery. And I can remember being very frightened, really, as a young neurosurgeon coming to town when Dr. Carrington Williams, who was one of the most prominent surgeons in Richmond, developed a disc and asked me to come up to one of the other hospitals in which he was the chief surgeon. He also asked me to do the operation. I suggested somebody else, but he said no, he wanted me to do it. And also took an anesthetist from MCV to the other hospital. And at operation, he had a large extruded disc. And he's one of the fortunate people when, as soon as the disc came out, he was cured. He had no more trouble at all. And so I was moaning because he waited for a week before he did have the operation. And I awakened every night screaming, young neurosurgeon comes to town, and old neurosurgeon is crippled. How it was the greatest thing that ever happened to me because the word spread that somebody could really help with this. I was always fond of doing the trigeminal neuralgia operation, but and when after Dr. Coleman died, every case that I did after that, I did by posterior approach.
You also apparently enjoy doing meningioma cases.
I love meningiomas. I think they're glorious. The only bad thing that's come up in recent surgery is there's been some recurrences of the meningiomas. We'd always thought they weren't coming back. And for the most part, they don't come back. But it is lovely to operate upon a patient who you are sure in your own mind has a glioblastoma and find out that it is a meningioma, and you could get good cures.
You have lived through a great era in neurosurgery. What, if you look over the period of your practice, what were some of the great, or maybe even the greatest advances, or things that have had the greatest impact on the practice to help neurosurgery, the neurosciences, that you've seen in your lifetime?
Well, certainly the introduction of the microscope into it has been one of the greatest ones, although it is vastly overdone. I've, on occasion, have seen someone opening a scalp wound under the microscope, which didn't make any particular sense. I think that has done, I think in overall picture of neurosurgery, that I was very fortunate that I came along at the very heyday of it, that it was at its very greatest. We were our own doctors. We had very little to do with the finances. Everything was taken care of, and you, for the most part, had a very close relationship with each patient. And I think one of the unfortunate things about modern-day medicine is that there has been a loss, to a large degree, of the patient's contact with his doctor. And that there's been a loss of some respect for the people. The financial end has come in so much. And the lawyers are always gunning for the doctors as well as the insurance companies and the government in general. And so I think the loss of respect has been one bad thing in that relationship.
What do you predict for the future of neurosurgery? A young man who would come on the scene now, say just out of residency, what could he expect, you think, the next decade or in the future? What do you see down the road for us?
Well,
you said we had our heyday, or we saw...
I've been out of it for 3 years now, and I say up until 10 years ago, it was a pure delight to be a neurosurgeon. You had patients you could help, you had patients you could do things for, you had patients whom you admired and they admired you. I think that the gradual encroachment of the government, of insurance companies, and particularly lawyers, has been a bad feature, and I'm sorry to say I don't see any relief. Governing bodies are increasingly run by lawyers who pass laws mainly against us. And I would say that a young neurosurgeon coming out in some communities are going to have an awful time when they come up with the size of malpractice insurance.
Do you think we have enough neurosurgeons, or training too many? And would you expound a little bit on the concept of certain centers, let's say, that would treat, say, for instance, aneurysms? How do you feel about the current state of the art of neurosurgery, the way it's conducted?
Well, I would say that there ought to be more centers that major neurosurgery, although I did quite a bit of major neurosurgery in very small hospitals. I don't think that it is the right thing. I think that many things in neurosurgery can be done in the smaller hospitals. They opened up more instruments and making things more available. But for the most part, a major aneurysm, a major brain tumor, a major spinal cord tumor, I think ought to be in the center. I think it's probably a good thing as they have in Maryland, in which pediatric injuries, neurosurgical injuries, all go to Hopkins. All adult neurosurgical injuries go to the University of Maryland. And they both are lined up to take care of that in particular.
You mentioned you retired about 3 years ago. Tell us what you're doing in your leisure time, and particularly Dr. Troland, tell us a little bit about your very closely knit travel club and some of the members and some of their contributions. You've had a unique vantage point to be warmly associated with many of the giants, not only Dandy and Coleman, but currently you have a very close-knit
Yes.
group that you travel with.
We have, in the Neurosurgical Travel Club, I think we have the closest knit group anywhere, and I attach that largely to the fact that the ladies were brought into it and the children. On many of our earlier meetings when we had smaller children, and even later, any of them that are around, we are all very closely related. We all have excellent camaraderie. I don't think there's a single bad egg in the entire group. And I've never missed one of the travel club meetings. We started out with the idea that we were going to be small enough, and we were 16. We started out enough so that we could all get into the operating room well, and somebody did one operation for us. And we're very, very close-knit. At the present time, I go to all the meetings. I'm going to one next month, or late this month. But I've gotten away from neurosurgery. I think I got out at the right time. I was still very active in neurosurgery, but the malpractice insurance was beginning to skyrocket even more. I didn't think I was as good a neurosurgeon. If a real bad emergency came up, I was not sure that I could take care of it the way I used to. I didn't want to stay in it then. I write some about my experiences with Dr. Dandy, and I'll go around and see these other people. I have a wife and 2 children, both of whom are lawyers, both of which I would have thought early in my life was perfectly horrible, but now I'm not don't think it's a bad idea at all. But I've enjoyed, I think when talking about retirement, it depended on how much you like what you did. But I can see the man who is standing on a line just turning a wrench or something, that he would eagerly await retirement. But retirement in someone who's very eager, who liked his neurosurgery, is on some occasions kind of hard to take. You, on occasion, get out of bed at early morning, you get dressed and go out the door and say, well, where am I going and what am I going to do when I get there? But we travel widely, and I have a very happy home and 2 successful lawyer children. So all in all, it is as good as I could expect.
You mentioned, Dr. Troland, a few minutes ago, some of the advances in neurosurgery and the use of the microscope. My beloved professor and teacher is a member of your travel club, and he was instrumental in the development of the shunt for hydrocephalus. And you worked with Dr. Dandy on the ventricular system. Where would you place for instance, the use of the shunt in neurosurgery? The valve-regulated shunt, for instance, came to be in your lifetime.
Yes.
You did not have that when you started training,
No, the only
came around in the 50s with Dr.
The only thing that we had was we would do an occasional shunt from the ventricles into the posterior fossa by way of a catheter. Now, I've used those and seen them do well. I think Dr. Nelson's work has certainly been fantastic in hydrocephalus and has turned a new look on it. I never did do a great deal with hydrocephalus because I never liked working on the hydrocephalic children. Dr. Nelson has loved it and done a great job.
How about the use of steroids and Decadron? Overall, do you think that's had a major influence on steroids are used so routinely now in neurosurgery, and you were on both sides of the use before and after?
Well, I think before, of course, we didn't have them, and afterwards they're vastly overdone. And I've seen cases in which the doses have been terrific and have done, I think, irreparable harm and have led to some rather large malpractice cases. But there's some things that we didn't have, and we seem to do awful well without them. But I'm certain that steroid work and steroid usage has been a tremendous contribution. I think it's saved an awful lot of people who used to have pituitary disease, marked pituitary disease.
This concept, we tend to make people bigger or greater in death than we do in life. Were people like Dandy and Cushing, were they really unique men and individuals and, as it were, giants in their time? Or do you think that we look back on them and give them more credit than they deserved? Or were they extremely unique people?
I think some of the people that I knew were unique, and time has added nothing really to them. They were great then. I would say particularly one of the people I started with, Dr. Philip Bard, who came down from Princeton to take over neurophysiology, was one of the greatest gentlemen I ever saw in my life. And certainly an underrated person was Dr. Samuel Crowe, who was originally going to Boston with Dr. Cushing, when Dr. Halstead said he wanted him to be the first professor of otolaryngology. And so he stayed and became one. But Dr. Frank Ford and Dr. Frank Walsh, time has done nothing. It's added a luster in thinking about things, but they were great people, really great people.
As you look back on your life and your professional career in neurosurgery, is there anything you would like to have done differently, or would you change anything if you had to do it over?
Well, I think I'm one of the unique people. I don't know originally why I went to Hampton, Sydney. My family were not from Hampton, Sydney, but I went to Hampton, Sydney. I'd go back again. My son went to Princeton, but I wanted him to go to Hampton, Sydney, but he wanted a place with a bigger library. But I would go to Hampton, Sydney, certainly by all means. I would go to Hopkins, and by all means I would certainly appreciate and love the contacts that I had with Dr. Ford and Dr. Frank Walsh, and particularly Dr. Dandy.
You single out Dr. Bard. Would you say he is the one person who had the most influence on you? You mentioned your mother early on, but can you, one person that may have meant more to you or influenced your life more than any other person?
Dr. Dandy?
It's Dr. Dandy.
Yes. But there were so many. I have lived a particularly nice and fortuitous life. Maybe there have been different occasions. I've wondered sometimes what would have been different if I hadn't run into Dr. Overcash that day walking across Hampton, Sydney. And really, he set me down to thinking. I'd never thought of what I wanted to do. I was just going to be a lawyer because I talked a lot. And he set me to thinking about it, and he exerted a tremendous influence, which is an example of what a good place Hampton, Sydney is, because he didn't even teach me but one class, and he had taught that in my sophomore year, and he asked me this question. He chose the quality of the men looking after the students and all to a great degree. But I think overall, although I wasn't with him for a long time, I was with him more than anyone else was, I think that Dr. Dandy, in his quiet way, was the greatest influence.
I'm certain that people who look at this interview, Dr. Troland, in years to come, probably would like to know a little bit more about Dr. Dandy. You said he was an excellent surgeon, that he was a taskmaster, and that you had to know the answers at 2 a.m. But what was it like working day to day, rubbing elbows? Was he awe-inspiring? Was it hard work? Did you enjoy it? Was it fun? What was the day-to-day life with him?
The day-to-day life was hard. It was terrifically hard, but terribly interesting. Dr. Dandy was so well known that when other people had problem cases, they sent them to him. And it was interesting. He didn't tell you about anything that he was thinking. You had to ask him if you wanted to know. But he felt that neurosurgery, which I do very strongly, is a grown-up science. That you're not really ready for neurosurgery when you're a third-year medical student, although you knew more than anyone else did when you were a second-year medical student. But his influence was great also on Dr. Ford and Dr. Walsh. They came around and they learned things from him, and he learned things from them. But they were a wonderful group, but I think in his quiet way, although he could be rather nasty on occasion, in his quiet way, he influenced more as to what I did.
Did you ever have any social or personal contact with him outside the hospital?
Dr. Dandy had very few personal contacts with the house staff in particular. He gave one boy who was going to get married a party at the Baltimore Country Club. That's the only big social contact that he had the whole time. He had a fad of calling people by different names. He called Watson Watkins. He called Ravitch that Rowwich. And he called me Tolson. And I was amazed when I came back from overseas, we'd been gone for 3.5 years, to hear somebody in the halls at Hopkins say, Charlie. And when I looked around, it was Dr. Dandy. And it had changed the relationship there.
We hear this term that's been passed down, maybe orally more than written, the so-called brain team. What really did the brain team mean? Is that just the residents and Dr. Dandy, or?
The brain team was the resident and the assistant resident and the intern who passed through on very quick, and Dr. Dandy.
Was that a term used at that time at Hopkins?
Yes,
you were called the brain.
Dr. Dandy used it himself as a brain team. The one element in it mainly was the operating room nurse, who was his own nurse. She only worked for him. And I guess a part of the brain team was Lawrence, who was the orderly. Lawrence was a dwarf, and he had no clavicles. But he was devoted to Dr. Dandy, and when Dr. Dandy died, Lawrence died a month or so later. But it was a great experience. Because of the enmity between Dr. Dandy and the operating room nurse, nobody could go into the room until 8 o'clock. And so it was something to see the assistant resident and Lawrence have the patient balanced on their shoulders, ready to rush in to get a ventriculogram at the 4th stroke of the bell of 8.
Dr. Troland, as we wind this interview up, is there anything else you'd like to mention about your life and your career?
I'd say I have been extremely fortunate. Some of it has been entirely fortuitous, running into Dr. Overcash and Dr. Dandy speaking a word to Dr. Lewis for me, and things like that made a tremendous difference and really molded everything I had in my career. I've been primarily what is known as a clinical neurosurgeon. I've not been in a great institution doing research for a long time, but have been primarily taking care of patients. And I had a large number of disc patients in the city, and my wife has said that we have never been on a trip that we haven't run into somebody I've operated on. I think that's somebody rare that I have. But I've been lucky. I've enjoyed neurosurgery. It's been a tremendously good life, And whereas I'm glad my children are not going to get into it, I think it can still be a great life, but it's going to be a rougher life than it was. I do not believe that a lawyer knows enough medicine to take care of neurosurgical patients. And that is what the tendency is.
Well, Dr. Troland, thanks for this interview, and I'm sure it's been a privilege for all of us to look at this in years to come.
Thank you.